Idiopathic macular holes are a complex of vitreomacular interface disorders with a prevalence of 3.3 cases in every 1,000 individuals over the age of 55 years. Management till date included just PVN induction, which gave a success rate of 50 or 60%, ILM peeling, which gave a success of 80%, and the inverted ILM peeling technique, which gave a success of 90%. There have been many modifications for macular hole closure, such as the four-wheel splitting ILM peeling, the ILM abrasion, the inverted flap technique, single-layered, multi-layered, the cover and fill technique, viscoelastic assisted ILM stuffing, ILM dragging and peeling, ILM inverted flap with autologous blood application, and of course, fibrin glue assisted closure. The biggest trouble after peeling the ILM is to keep it covered over the macular hole and to avoid slippage of the ILM, especially during the fluid gas exchange, which can cause opening of the macular hole. We present Dhami's ILM plugger. It's been designed by us and made by Epsilon. It's a 25 gauge instrument with a flat round base which allows for easy manipulation of the peel interlimiting membrane and plugging of the macular hole with minimal damage to the surrounding tissue. Let's have a look in this video. We're using Dhami's ILM peeling forceps, which allows for scraping the ILM and peeling it simultaneously. Once we have obtained a C-shaped flap, we remove it from all sides of the macular hole, keeping a small nudge attached. Then with the help of the 25 gauge cutter at minimal aspiration rate, we trim some amount of the free floating ILM. Once that is done, we bring in the Dhami's ILM plugger, and with the help of that, we stuff the ILM into the macular hole, thus allowing a complete macular hole closure. In the end, we just do a fluid gas exchange, and you can see that the ILM that is stuffed into the macular hole is not at all moving. It's pretty stable, allowing for a better closure. Let's have a closer look. Now you can see that we are using the Dhami's ILM plugger, and once we have had the adequate amount of ILM, we gently just tap the ILM into the macular hole, and you can see that we're pretty superficial. We're not pressing into the RPE. We are just putting the ILM into the macular hole, thus allowing a complete macular hole closure. Image A shows the open macular hole. Image B with a red star shows the complete closure, a type 2 closure for macular hole. The image C, you can see that the post macular hole closure, the fundus image is absolutely perfect, and the fundus autofluorescence shows no underlying damage to the RPE. Why is this instrument needed? Despite inverting and folding the ILM flap such that it covered the hole's entire surface at the end of surgery of fluid gas exchange and surgical closure, MH reopening is noted with ILM flap to be folded over the retinal surface at or below the inferior edge of the hole. It is possible that the ILM slips downward during fluid gas exchange or in the early postoperative period, especially while doing fluid gas exchange. To conclude, the Dhami's ILM plugger gives a significant promise as an easy approach for treating large, full-thickness macular hole surgery. The Dhami's ILM plugger technique has achieved 100% anatomical closure till date for macular holes over 500 microns, and it may also limit us for the need to use long-acting gas tamponades or even preventing postoperative bone positioning. Thank you.